Good morning, everyone. Dr. Rashid, he is our pediatric neurologist in Al Ain, the Heart Medical Center. Dr. Rashid, he was working in the last 15 years in UAE, and over the last 10 years, he was working in pediatric neurology in Liverpool and Leicester University. He's going to speak today for a very interesting topic about headache in children. Please allow me to introduce Dr. Rashid. Good morning, Dr. Rashid.
Good morning, everyone. Thank you very much, Dr. Dalal, again for this nice introduction. Actually, today's topic, headache, is too huge a topic to be covered in one presentation. But I've tried my level best to just have glimpses of various aspects to at least have an understanding of the topic. Right. Okay, so now starting with what is headache. So headache is actually the pain located above the orbitomeatal line. Any pain below is actually a facial pain. Now, looking at epidemiology, this initial information about the prevalence is actually from a systematic review based on 50 population-based studies, which states that 60% of children report at least one headache during their childhood, which is a huge number. And 20% of the children between 4 to 18 years, they report recurrent headaches in the last 12 months. 1.5% of middle school children between 12 to 14, they report chronic daily headaches, which are basically 15 or more headaches a month for more than 3 months. And now gender prevalence under 12 years is equal both in girls and boys, but after that, girls outnumber boys. Now, broadly speaking, headaches are divided into primary headaches, which means headaches intrinsic to the nervous system or brain, and secondary headaches, which are actually symptomatic to some other cause. Now, if you look at the list of primary headache disorders, there is a long list, but the three first on the top are main primary headaches. But I can quickly go through that list of primary headaches, which means migraine headaches, tension type headaches, trigeminal autonomic aphalgias, one of which we'll discuss today is cluster headaches, cough headache, exercise headache, headache associated with sexual activity, primary thunderclap headache, cold stimulus headache, external pressure headache, stabbing headache, pneumolar headache, hypnic headache, and new daily onset persistent headache. The first three primary headaches which I mentioned, just a comparison for a better understanding. So location-wise, migraines in children particularly are bifrontal in location, but in adolescents and young adults, 70% of them are unilateral, but 30% are still bifrontal or global. Tension type headaches classically are actually bitemporal headaches, they are bilateral, and TACs, particularly clusters, they are invariably unilateral. So if a child or a young adult has bilateral headaches, so cluster headaches will not be in the differential diagnosis. This is as far as the question is concerned. Characteristics, migraines are generally gradual in onset, but they are crescendo. So from milder severity, they will develop into severe intensity. They are pulsating in character classically, and they are moderate to severe in intensity. And very important, one of the questions in the diagnostic criteria is the effect of physical activity. So physical activity actually aggravates them, and as a result, children prefer to stay still or rest in a quiet and dark place. Tension type headaches, conversely, are basically pressure or tightness around the head, or it can also be felt actually on the back of head and in the upper back muscles as well. Now, tension type headaches are mild to moderate in severity. These are actually not aggravated by physical activity. And cluster headaches, if you look at them, they are again crescendo headaches, but they develop from milder to severe intensity very quickly. So as opposed to migraine headaches, which are actually gradual in onset. These are quick and faster. And the location of the cluster headaches is actually retroorbital or periorbital, or they can be temporal, but unilateral always. As far as the appearance of the patient is concerned, I mentioned earlier, patients prefer to stay quiet and prefer to stay in quiet and dark place, and they prefer to be less active. Tension type headaches, they are generally not affected, but very interestingly, cluster headaches, one of the requirement for diagnosis is basically they are restless. So this is very important. They are moving around and they are restless. And the duration in children, it is from 2 hours. Some people take from 1 hour to 72 hours. In adults, it's 4 to 72 hours. Tension type headaches are variable. They can vary from 30 minutes to 7 days. And trigeminal attacks or cluster headaches particularly, they vary from 30 minutes to 3 hours. Now, associated features in migraine can be nausea, vomiting, photophobia, phonophobia, and if there are auras can be visual, sensory, speech / language, motor, retinal, or brainstem auras. Tension type headaches, they don't have any auras, and cluster headaches actually are associated with the autonomic features, which are unilateral, and they can range from eyelid swelling, redness of the eyes, lacrimation of the eye on one side, and watering from the nose on the same side. There can be puffiness of the face on that side, and fullness can be felt in the ears. Now, although just to have a pictorial understanding, because just for, I'm a visual learner also, so I prefer the visual component. So clusters are generally around the eye, and tension types are diffusely distributed and bitemporal particularly. Migraines in older children and young adults are unilateral, but in younger children, they are bilateral. Now, this is just again for better understanding than the words themselves. If you look at migraine and cluster headache periodicity, so cluster headaches actually tend to occur from multiple times a day, and they can run for many days to weeks and months, and then there can be a remission. So these clusters are very closely placed, and they can range from 1 to 8 episodes a day to 1 episode every other day. However, when we look at the pattern of the migraines, their periodicity is not as frequent as it is seen in cluster headaches. Now, this is again just to have an idea. Migraines with auras, we know that they can have a prodrome, then there is an aura, and then actual headache phase, and followed by a postdrome, as they say, of tiredness and difficulty. If you look at cluster headaches, they can also, although they don't have an aura, but they can have a prodrome, and which is similar mood changes, and there can be alteration in appetite, or there can be craving and restlessness, yawning, and all those. So there is some similarity in the pattern, although they don't have an aura. Now, these are criteria from International Headache Society guidelines. I just quickly go through it, because whenever you are dealing with the primary headaches, you have to apply this criteria to make a diagnosis. Now, looking migraine can be without aura or with aura. So requirement is for without aura, you should have at least 5 episodes, and these should meet B to D criteria. Headaches attacks lasting between 2 to 72 hours, and headaches has at least 2 or more of the following, which is unilaterality or unilateral location, pulsating character, moderate to severe pain intensity, aggravation by or causing avoidance of routine physical activity, which I mentioned earlier. And D is during headache, at least one of the 2 should be there: nausea and or vomiting, photophobia and phonophobia. And E is not better explained by other criteria. With aura, I will leave the details there, but with aura, you need only 2 attacks instead of 5 attacks. And then there can be an aura, which can be visual or more than one: visual, sensory, motor, language, retinal, or brainstem type of aura can be there. So number of attacks matter here. Now, going to tension type headaches, there are episodic tension type headaches, and then chronic tension type headaches, and episodics are further divided into infrequent and frequent episodic. So the most important thing here is the numbers. So you need to have at least 10 episodes before you make a diagnosis, and infrequent episode will be less than 1 episode a month. So I'll leave the rest because we have discussed already earlier. So, and when we go to frequent episodes, so now they are 1 to 14 episodes a month, and I mean lasting for about three months, and then we know the characteristics of the tension type headaches. Now, cluster headaches. Now again, you need 5 attacks episodes. If you look at the severity scale, cluster headaches are the most severe of the 3 primary headaches we have discussed. Now, duration here is 15 to 180 minutes. As I told you earlier, a frequency can be 1 to 8 episodes a day to 1 episode every other day. Again, other features I have discussed. The most important part is basically unilateral autonomic features. Because I have a bigger presentation and I have 6-7 cases at the end, so I'll try to run through. Okay, now headaches. Okay, before I move to headaches due to IIH, now chronic daily headaches is, which I have not brought the slides here. Chronic daily headaches are the headaches which are 15 days, more than 15 days a month, for 3 months or more. Okay, now under that heading, chronic daily headaches, we have chronic migraine headaches, chronic tension type headaches, and we have post-traumatic headaches, and we have chronic, medication overuse headaches. So that criteria will apply to all of them, and we'll discuss in a short while. Now, headaches attributed to IIH, this is from secondary causes. Now, IIH is idiopathic intracranial hypertension. Okay, headaches attributed to IIH are basically IIH should be diagnosed when the CSF opening pressure is 25 centimeters of water, and there is no evidence of CNS infection or any other pathology. So this will give you a diagnosis of IIH. Now, IIH in children, they have raised the cutoff for pressure, particularly obese, less than 8 years old children. It can be 28 centimeters of water. Now, so headache should have a temporal relationship with the IIH, and it should be relieved by when the intracranial hypertension is relieved, and headache is aggravated on temporal relation to increase in intracranial pressure. So this is the criteria from the secondary headaches. I have taken one example here. Now, secondary headaches, now, as I mentioned earlier, primary headaches are basically a long list of those, but from the primary list, we discussed 3. Now, secondary headaches can be due to causes which are intracranial, or the causes can be outside cranial, which is extracranial, or there are miscellaneous group. Inside the brain, if looking at the different structures, so we know CSF is there, so high pressure can cause headaches, and the IIH is one example. Low pressure can be a cause of these headaches, like low pressure, low CSF pressure headaches, for example, following a lumbar puncture. And there can be vascular structure which can, like AV malformation, they can cause headaches. Then there can be a space occupying lesions such as tumors, and there can be brain abscess. So a long list of intracranial conditions can cause, and following trauma, you can have bleeds of various kinds, which can also cause secondary headaches. Now, extracranial, basically, most common are sinusitis, otitis media, tooth abscess, and TMJ dysfunction. Now, miscellaneous, actually, from this very important cause is medication overuse headaches, and headaches which co-occur in patients who have mental health comorbidities. Now, it is the same actually repetition of just for that visual memory, that extracranial can be sinuses, ears, teeth. These are the sources, and TMJ dysfunction, and intracranially going by structures, fluid, vascular malformation, bleeds, post-traumatic, and SOL. So these are depicted here. Now, I find this slide very, very important, because when you are taking history and trying to decide which type of headache this is, so before you categorize them into primary and secondary headaches, if you know the patterns, from these patterns, acute headaches and chronic progressive headaches are generally most of the causes are secondary, whereas acute recurrent headaches and chronic non-progressive or mixed pattern, these are either primary headaches or after transformation or chronification, they have become chronic daily headaches. So recognizing these patterns is very, very important. Acute headaches will be a steeply progressive headache occurring on a short period of duration. For example, it can be intracranial infections, meningitis, encephalitis. It can be, again, as we discussed earlier, extracranial. It can be tooth abscess. It can be otitis media. It can be a sinus. So these are all acute examples. I have slides of those also. In acute recurrent, just remember 3: migraine, tension type headache, and cluster, although a long list of those is included there. Chronic progressive headaches, very, very important. 2 significant examples in this group are idiopathic intracranial hypertension, IIH, and number 2 is space occupying lesions. So this is very, very important secondary cause, and this is important because you don't want to delay diagnosis, and you might need to refer these patients to a relevant specialty. And then chronic non-progressive headaches are basically that chronic daily headaches which I was mentioning to you. And under that heading, we have chronic migraine headaches, chronic tension type headaches, and we have post-traumatic headaches, and we have new onset daily persistent headaches also, and medication overuse headaches. If you look at the mixed headaches, this is actually a very interesting group, and a lot of teenagers, when you come across, they tend to present with this presentation. These are actually primarily primary headaches, which were episodic to begin with, but now with time they have transformed, and there can be an element of a migraine headache spiking on the spikes you see there, and there's going to be a background headache, tension type headache, and there can also be an element of medication overuse headaches. From my clinical practice, I mean from our clinical practice also, when I was in UK, we have come across a large number of teenagers, adolescents in this age group when they present to neurology. This is very, very, I find this slide very important from the clinical point of view. Now, from the primary and secondary headaches, what are the causes which will go under acute headache pattern of headaches? It will be infections, as I mentioned, sinusitis, otitis, viral upper respiratory tract infection, CNS infection, meningitis, encephalitis, brain abscess, and even systemic infection like having a febrile illness. They can all give you acute headaches. Post-traumatic headaches come in this acute trauma, road traffic accident. I have recently seen a young girl here who was sitting on a chair, and that chair toppled. She hit her head back. There was no loss of consciousness, but there was a concussion. After a few days, she started having headaches, which were actually consistent with the cluster headache pattern. So post-traumatically, you can have headaches which can resemble a migraine, which can resemble a tension type headache, and which can resemble a cluster headache also. But these are kind of secondary headaches here. Hypertension, hypertensive encephalopathy, other important causes which can present acutely. Never ever forget taking blood pressure in a young child who present with headaches. This is very, very important clinical practice. Okay, toxins, I'll leave there, I'll move on. Now, acute recurrent headaches, as I mentioned earlier, I'm now fitting the same causes into different headache patterns. So this is very important, because when we will go to evaluation, we have to apply this approach. So migraine headache, tension type headache, and cluster headaches. Chronic progressive headaches, which I mentioned earlier, chronic tension type, chronic migraine headaches, post-traumatic, new onset, daily persistent headaches, and medication overuse. Okay, chronic progressive headaches, idiopathic intracranial hypertension, space occupying lesions, we have discussed. Now, very important to remember, always keep red flags in mind, whether you are sitting in an outpatient setting or you are in a hospital. So red flags can be in history. Age less than 3 years is a red flag. Duration of headaches less than 6 months is a red flag. Headache features: progressive headaches, occipital headaches, headaches which awaken you from sleep, early morning headaches, headaches worse on lying down, headaches worse made by coughing, straining, or bending forward. These are actually red flags. And now history, again, associated features like persistent vomiting, altered mental status, ataxia, motor sensory visual, speech symptoms, personality change, academic decline, no response or failure of medical treatment. These are all red flags. History, again, past medical history of sickle cell disease, immune deficiency, malignancy, coagulopathy, neurocutaneous syndromes, a child with hydrocephalus or VP shunt, head trauma, these are all red flags. Physical examination, abnormal physical signs, high blood pressure, fever, neurocutaneous stigmata, abnormal pubertal status, signs of head trauma, increased head circumference, presence of VP shunt, cranial bruise, altered mental status, signs of high pressure headache, which is headache worsening on coughing and bending forward, and papilledema, retinal hemorrhage, diplopia, abnormal eye movements, ataxia, weakness. These are all red flags on examination. Now going to evaluation, which is a standard approach, history, examination, and investigation. I follow this approach. Again, people might have different approaches, but I feel that a medical student history taking and a clinician history taking have one basic difference. At medical student level, you are generally asked to characterize different symptoms like headache, pain, sight, severity, radiation, and those kind of things. But when you are a clinician, your history taking should also be based on differential diagnosis. If you have a differential diagnosis in mind, then you can tailor and focus the history and ask specific question. You will not be lost in random questioning. Okay. So first ask about, you want to establish the pattern of headache. We said acute headache, acute recurrent headaches, chronic progressive headaches, chronic non-progressive headaches, or acute on chronic, which is a mixed pattern. So what do you need for that? So ask the onset of headache, duration, frequency, and clinical course, whether it is acute, whether it is acute recurrent, whether it is progressive, progressively worsening, or whether it's a chronic non-progressive. So first thing, when you start history taking, ask these questions to establish first whether this patient is acute headache, acute recurrent headache, because that will reduce the amount of questions you will be asking, but yet you will be specific. Okay, so first establish the pattern of headache. And if it is acute headache, you know from acute headaches, we discussed what are the causes there. We discussed infections, we discussed trauma, we discussed intracranial bleeds. So all those will come in that. Although primary headaches also present first time, that can be there, but that will be lower down. So if you, for example, in this group, you think that it is sinusitis, so you will be asked questions related to sinusitis. You'll ask upper respiratory tract symptoms. You'll ask for any facial pain or any change in the headache as the day passes along. So your questions will be very specific. And similarly, if you ask about, say, for example, a pain which is from a tooth problem, I have seen young children having treatment, dental treatment, and following that they have a pain which is also associated with headache. So ask specific questions. Similarly, chronic progressive pattern, which I discussed earlier. So IIH questions. What questions you will ask in IIH? You will ask intermittent visual obscuration. You will ask pulsatile tinnitus. You will ask them ocular diplopia on lateral gaze. You will ask them, is there any high pressure headache, which is coughing, straining, bending forward, aggravates your headache. You will ask these questions, document as negative answers so that your history is complete. Very important. Similarly, if there is a infratentorial tumor, so you will have a child who has headaches. Headaches are more back of the head headaches, and headaches can be associated with vomiting, balance difficulties. So you will ask specific questions. Similarly, acute recurrent pattern, when you will come to this, you should think about migraine, you should think about tension type headache, and you will think about the cluster headaches. Now, accordingly, you will ask specific questions. You will ask aura questions, you will ask duration of the headache question, you will ask associated features, and your question and history will be very specific. And that history, if it is reviewed, written, and it will look pristine, a very good history. Similarly, non-progressive transformed headaches, as I mentioned earlier, these are chronic migraine headaches, chronic tension type headaches, and medication overuse headaches, and post-trauma headaches. Next, examination. Do a thorough examination. Vital signs, blood pressure, as I mentioned, never forget to take blood pressure in a child who has headache. I'm repeating it. Never forget to take blood pressure in a child who has headache. Okay, growth parameters, you can have abnormal growth parameters associated with secondary headaches. For example, a child who had hydrocephalus, he will have a large head. He might have some secondary features appearing also. So a lot of those things will help. Pubertal status, the children with the hydrocephalus, they tend to have precocious puberty kind of thing. So these can be helpful. Neurocutaneous stigmata, caffeolar spots, TS, and Sturge-Weber syndrome, all these are important. Now, neurological examination, you start with craniospine, very, very important. In tension type headaches, you want to elicit scalp tenderness or pericranial tenderness, very, very important. So when you're examining it, you'll gradually gently palpate all over scalp and and elicit tenderness. And if you can find those trigger points, that supports the diagnosis of tension and type headache. Similarly, temporomandibular joint dysfunction you can find tenderness there. And then you can in carry malformation, for example, there can be limitation of, there will be posterior neck pain and there can be limitation. You can have cranial bruise, VP shunt can be felt, spina bifida, altered mental status, as I mentioned earlier, signs of meningeal irritation, again acute, secondary type of headache, cranial nerve examination, as I mentioned, is very important. While you are taking history, always use headache diary. I use Migraine Cluster Headache diary. You can use anyone. They are available on App Store and Google, whatever those stores are. But it is very important because when they come to your clinic, they may not remember everything, but send them back with a headache diary. They should come back with a more precise information. Okay. The neuroimaging and lumbar puncture in headaches. Okay, so I'll talk about neuroimaging. Neuroimaging, why do you want to do it? You want to do it for secondary causes which are intracranial. So as I mentioned, you can have acute headaches which can have intracranial problems. For example, headache leading to, trauma leading to bleed. So you will need a CT scan. If there is a chronic progressive space occupying lesion, you will need an MRI. So that imaging will be important. Okay. So abnormal neurological examination and neurocutaneous syndromes, all these would require neuroimaging. I will skip to lumbar puncture. Lumbar puncture, again, it's a hospital thing, but two areas. One, where you'll have suspected meningitis, you need this. And second, very, very important, is to measure CSF opening pressure. Indications of referral, again, secondary causes, failure of medical treatment, and associated psychiatric manifestations or comorbidities. These are very important indications for referral. Lifestyle advice, this is from management general advice. I use this, you can use whatever you like. Adequate hydration, meal regularity, sleep hygiene, minimal screen time, regular physical activity. Water requirement, this is from European Food Safety Authority on how much fluid children should use. Rough guide, 4 to 8 years old girls and children, boys, they need 1.1 to 1.3. And from 9 to 13 years, roughly 1.3 to 1.7, depending upon the gender. But again, it's variable. And then sleep requirements, according to sleep, Academy of Sleep Medicine. Again, for headaches, particularly school age group is important. So 9 to 12 hours per 24 hours is important. Meantime, American Academy of Pediatrics discourages media use in children under 2 years, recommends limiting older children's screen time to 1 to 2 hours. 20 to 30 minutes daily. Okay, prognosis, this is very interesting. Remission occurs in only 44% of the children with tension type headache and 28% in migraine children. So not everyone can remit. So very, very important that when you see these children and you are giving them management explanation, counsel them that zero headaches is not a goal. If we get about 50% reduction in severity and the frequency, that's a reasonable goal. Very important also that migraines can, or without order, can transform into tension type headaches and vice versa. Okay, so cases we can discuss next time if you want.
Thank you, Dr. Rashid, for a nice presentation. If anyone has questions, please.
If people are interested next time, these are all clinical cases from clinical practice in UK as well as from here. So if they're interested, we can discuss those. Next time.
I think next time we can only have the presentation, the case scenarios. Thank you, Dr. Mohammed. Thank you, Dr. Rashid, for this nice talk. And see you, inshallah, next week.